It is a great pleasure to introduce Dr. Costas Panayotidis. Costas is a consultant in obstetric and gynecologist with expertise in infertility, early pregnancy, minimal access surgery, and advanced gynecological ultrasound. He holds multiple academic titles, including MRCOG, MSc, and MD, and has completed extensive education in France and in the UK. With a background in research and reproductive science, he has published academic papers and contributed chapters in medical textbooks. Costas is a member of various prestigious medical societies, such as the Royal College of Obstetrics and Gynecologists and the ESHRE. He is active involved in medical education and is currently engaged in research projects and ultrasound standards and embryo transfer techniques for the ESHRE. The topic of this presentation today is optimizing the ultrasound image, knowing how to tip the needle, looks at the rotating position, makes safer and more effective of ovum pickup. So Costas, please go ahead.
Thank you very much, Professor, for your kind words. It's a great honor for me to participate to this International IVF Congress. And yes, I will talk to you about the ultrasound images of the tip of the needles and how we can enhance our effectiveness in OPU, which means oocyte pickup. I don't have any conflict or declaration of interest, is none. Allow me to talk to you about the background. I was involved with all these things a couple of years ago while I was doing my research for the clinical master in advanced gynecological ultrasound of the University of Cardiff in Wales. I conducted a Delphi survey, and finally I got 32 standards of practice, which were formulated and proposed to ESHRE. For those that may be interested, you can download or you can read the thesis for free, of course, where you can see how we can standardize interventional ultrasound. In 2019, finally, I was involved as an expert member of the expert group of ESHRE to write a guideline about the OPU. And actually, we are very honored to tell you that we introduced internationally the oocyte pickup OPU as a common word to describe the technique. We have written in a simplified text. You can download this and you can read it from Human Reproduction Open in 2019. The recommendations for good practice in ultrasound. It was a humongous work, and I took active part of it. And the interesting part of this ESHRE guideline is that first it was the first in Europe. I don't know if it's complete in international way as well. It's the first time that we put some standards of practice. It's not just a description. We've got a complete list of all complications in a concise document. We give him an interest on impact in research for any meta-analysis of the future, particularly for bias factors that we need to consider from now on when we compare techniques and effectiveness. Particular emphasis in ultrasound quality, clarity of the image and recording of these videos, and mainly to talk about training, but how we can evaluate our daily practice, how we can maintain our skills. From all this, I will select these points relative to the topic today. So I will talk to you about the ultrasound orientation, how we can see better, the use of color Doppler, the needle tip artifact visualization and rotation, how we can combine movement of the needle and the ultrasound probe. And we will talk as well at the end, I hope, if our time allows, about training and mainly appraisal of our practice. So I start and attacking directly. I hope that the image is quite clear. We have a nice overview here with follicles. We are all familiar, at least for the specialists, that we have a guide and a focal area. The focus is very important always to use. Don't underestimate the importance of this, because the focus is the area of conversion of the energy of our field so there is more reflection, and therefore there is a more clarity. So the final movements, the focal areas needs to be adapted on where you want to go with your needle. So usually it must be in the middle or eventually a little lower of the ovary. We are familiar as well with the guide, and the guide needs to be calibrated, and the operator or surgeon needs to know what kind of guide, because we can change the angles, and that can be sometimes a nuisance for our penetration on the ovary with our needle. So I was mentioning that the color Doppler can be useful. A lot of colleagues don't use it. I feel that having a complete study before we do any attempt to OPU gives us a more confident way to avoid potential complications, because we can see, as you see here, the vessels, the internal vessels between the follicles. For example, in this short video, you can see in this juicy polyfollicular or polycystic sometimes ovaries that we can have particular areas that they are very vascular. So it's not only to avoid complications, particularly these women, for those that they do OPU with conscious sedation, they tend to have more pains. And I have observed that it happens mainly when we pass these sensitive areas. So in this case, for example, it will be better to go in the middle of the follicles, avoiding the vessels. So it helps to give us more confidence for safety, but as well, it gives us an idea in 3 dimensions way, although that is bidimensional, the study, where to go. Here it is one of the needles that are commonly used. There are many, but I choose one of the common ones. And in this high resolution, I hope, photo, you can see that there are engravements in these little lines. Very few doctors really go through all these details. I mean, if we measure them, we have about 12 of these zigzag, and then we have 5 lines at the end. And then, of course, we have the little sharp tip. All these lines have been done by the manufacturer in order to create an artifact based on a reverberation artifact effect. So that what means that is that the sound is, some of the sound is reflecting in between these areas. So it creates a pseudo image of hypercogenicity. So with this way, as you see in this example, we have a needle. Okay, that's the needle, that is the right ovary. We have penetrated inside, and you can see different lines. Yes, this is the needle. The question for me was not only to see the needle and to avoid potential sharp complications and trauma. The point is to know where is the opening part of the needle to aspirate. So you need to know from where you aspirate. So when you see such image, you have this sort of line, which I call it golf button, is my own way of describing to my trainees. And then you need to know that the suction happens to the opposite side. It happens to this side here. So it is oblique, but this angle is where the fluid goes inside the needle. Actually, this image is this. So now, at least in my high resolution Mac, I can see here 5 lines, and I can see here 5 lines. And if you can measure, you can even find the 12 lines. It's very, very clear, this image. But it's not only to know where it is a tip and where you have this opening for the suction. From this moment, you can now rotate your needle depending on your needs and the morphology of the follicle anteriorly, meaning the opening face towards to us in our screen, or posteriorly backwards. And then what happens is that we have another image like this. And allow me with a little humor to call it like a Christmas tree. And we have these lines here. The only thing is that we sometimes we don't see the final tip completely of the needle. So if I'm allowed to go backwards, you may lose this one. It's 0.5 millimeter, but you can see all this exaggerated like a triangle. So yes, most of colleagues, they use this, but when you have this image, you need to know if you aspirate from the back or in front of you. So let's see an image now, a video of a penetration of this needle. The suction happens to this side, and slowly, of course, you can see the whole length of the iliac vessel, a small rotation, and now I rotate posteriorly for milliseconds, and I'm done. So there isn't any fluid. Of course, a lot of people do that. The main issue is that when you have 100% knowledge from where the fluid comes in, you have better opportunities to adapt a constant flow of negative pressure where the fluid exists. So it's not the fluid going to the needle only, is the needle going where the fluid is accumulated. Another reason to know the orientation, I will play again the video, is that you can have this higher part which is blunt. There isn't anything to suck here. So you know that you can move safely this higher up, lower is the fluid, and then you have a constant negative pressure and exposure of the remaining fluid. So this is a very important thing when we consider ovaries that they have funny shapes or they can have a lot of follicles, particularly the polyfollicular ones, that the follicles can have trapezoid shapes or banana shape, or they can have a bigger part and then there is another in between follicle and then there is a remaining of fluid of the same follicle somewhere else. In this small, again, example, let's play it once more. You can see the suction happens to the left side, to the monitor, to the right side of the patient. I am half in. Now I see that there isn't any movement suction. I penetrate a little bit further and I suck posteriorly, and now there isn't any remaining of fluid, and I'm going to the next one. Another example of how that helps us here, I don't usually do this sort of rotational movement anymore, but I was so close and I felt more confident to do with this way. I'm so close to the iliac vessels. But the main thing for the moment that you are inside, you can have complete freedom of where the fluid is accumulated. Now, one of the things that we are not taught, and there isn't a lot of, actually I haven't seen any textbook saying, is where is your orientation? Meaning that from which side, I mean, you start left, right, up and down, it's an empirical way, and a lot of doctors and professors and trainers, they tell you, you need to know where's your tip to avoid trauma, you retrieve your needle in the middle, and then you try to avoid any remain of fluid. But they don't tell you how. So I hope that these images helped and gave some tips. There are doctors that I talked to, even last month in Armenia, was in an international congress with professors from different countries. They found this sort of explanation very useful and practical. I hope that this is the same for you guys. Now, what happens with a single lumen and the flashing technique? These are ongoing debate whether one is better than the other. And from the ESHRE and the meta-analysis, it shows that the accumulation of the research using single lumen, one go suction, versus double lumen, which means with flashing once or twice. The single lumen gets as many eggs or sometimes a little more, and of course is shorter in time to complete. However, nobody, up to my best knowledge up to now, evaluated these two techniques depending where the needle position is and what kind of rotation we do. The ones that they tend to do flashing technique, they don't give so much importance on the finality of the ultrasound image. What does it mean is that you suck all the fluid, the white of the follicle starts, the wall comes, it's hyperechogenic, you don't move around, you give a go with a little fluid, and then you repeat the suction. So this is fine. However, those that they do single ones, they may tend to be a little more cautious in the setting, so they tend to see clear, and then eventually they do this kind of movements. So I would suggest such sort of hypothesis, and I would be more than happy, because here we are to share ideas, to collaborate with colleagues and professors that they may have the same interest about how really we need to compare this kind of techniques. Actually, what happens, in my opinion, is that we have a simplified flashing technique with a more sophisticated single one, and therefore this is why we have this tendency. We don't know what happens if we do with needle attention and rotation positioning in each step of double lumen or flashing technique. What is the difference? Perhaps there isn't. Perhaps the single one will remain the best. But it's an assumption which I would like to propose. Maybe that can help to clarify this once forever. Another thing that I want to mention is that the ovaries are different, or patients are different. So a good sonographer needs to adapt the settings and the clarity of the image on the patient, on the ovaries. So I have grouped the ovarian family in 4 groups. The PCOS, which are more sensitive when we do, under conscious sedation, not general anesthesia, the OPU. Then the ovaries that they may have cysts like endometriomas, dermoid, or they have been operated, so they have a scar from a cystectomy, or eventually they have been stuck somewhere that they are not normal positions. The low response ovary, and thank God that we have some normal ovaries as well. Why this is important? Because the settings and the finality, how we can see the needle and how we can see the follicles are different. These ovaries have different reflections and different settings. So, and particularly if now we know better from where the suction happens, left, right, up and down, we can have better success, particularly for the low response ovaries, where we can have a follicle that is on the top, then scattered between the follicular cortex, so they are not neighbors, so you may need to do more manipulations. I explained already for the PCOS or the polyfollicular ovaries, the knowledge of where the fluid is accumulated is important, because then you have a complete suction, you avoid microtrauma and rupture of follicles, and you avoid pseudomembranes. The worst OPU are the PCOS. The other ones are easier technically. Basically, apart this, each machine has some settings. Unfortunately, in my exploration in Europe, many IVF centers, even private, they don't use top quality machines. They use older type machines. So it is the operator who gets used to these images. So we need to seek always the best quality, the best clarity, avoiding complete automatization, but knowledge of the settings in order to personalize the settings in each case. So I have talked to you about the golf button, about the Christmas tree, about the gogenicity of the lateral walls. This is another problem when the follicle is collapsing, is very white, and then suddenly is containing all around the needle, and then you don't see where's the needle. So again, the settings and the filters that you need to use needs to distinguish needle from collapsed follicle. It's not so easy this, it takes some time, but if we get used to improve the images and used to the next patient, then you may have the 4 settings that I propose for the 4 ovaries. I want to show you, for example, different kinds of views. I mean, there isn't better if you have the probe from the top or the probe from below. For example, here you can see that there is almost parallel vertical, this guide, and you can see the little Christmas tree here. So you need to wonder where is the really end. This is an exaggeration. The needle is somewhere in the middle. Here is another image of rotating, so the golf button starts to appear. Do not use, in my opinion, 100% of power, because even if your machines are old or obsolete, because you increase the regions of whole artifacts. So yes, the image is brighter, but it's brighter everything. So you have problems when you do these final movements or when you complete the aspiration of each follicle. I mentioned the importance of the focus. These are the 4 types of positioning of the probes, left, right, up and down. And ideally, we need to see the whole length of the iliac vessels. Now, a reflection, some people, they don't rotate the probe 90 degrees. For example, if I go to the right ovary, I will turn my probe to the 90 degrees almost, to my left, to the right of the patient, up and down. So I see all the ovary, but then I can see the whole picture of the vessel. If you still use the probe longitudinally, just a little up and down, what happens is, yes, you can do, of course you can do the OPU, but you lose this part of the view. So in case, which is rare, but in case that you need to pass on the top of your ovary for a very strange or very valuable follicle, you may have serious potentials to traumatize major vessels. Another image where you can see the baton. This is the place where the suction happens, and then you have this blurred artificial sort of scattering of your ultrasound. So that's another sign to know where you are. Concerning the pressure, higher pressure you use, faster you need to do these maneuvers and this coordination between probe and needle. For the needle, to be clear, we have penetration, introduction, and retrieval, and we have left, right, some sort of rotation. You don't need to do 360 degrees by all means, because if you do 360 degrees rotation and you think that you suck everywhere, certainly you will touch and you be in contact with the wall and you will block your needle. So you need to orient where the fluid is and what you need to aspirate. For those that start this kind of work, 140, 160 is good. I use 180. Rarely now use high pressure 200, extremely rare to use turbo. This example may illustrate when you stabilize your needle, then you have the movement of your probe. For example, here, I discovered that there is a little more fluid and I move on. So if I go back and I started here, all right, so I'm in the middle somewhere there, here it is. Good, we suck, we decrease all the volume, there is a collapsing, you see the micro movements that I do, and then thinking that you are done, I keep my needle steady, hang on, stop here, and then I rotate a little my probe, and when I do that, you can see that there is a little pocket behind me, and then I orient now, posteriorly now, sucking with the needle, and then I have completed. I don't know, maybe it seems complex to some, but with a little bit of interest and practice, you can have constant knowledge where you are. For example, in this case, I will show you where is the needle tip. Yes, very close to the vessel. I just penetrate here. I suck, I'm almost done, but there, I don't know if you see my little cursor. Here it is, here it is, here it is. I am inside, I have movements of my probe to be sure that there isn't any remain, it's almost at the end of the OPU here. So it is small things. I will pass very fast on these videos, just the photos. Again, the images, the strategy from where you start, middle, lateral, at the end, you can always evaluate with a Doppler where you have a complication, what happened and how big and well it seems to be the ovary. But as well, not only the ovary, the complete one here, for example, at the left side, or the cervix, or the uterus to the right side. There's no point to show you these things now. This one is more interesting because we have a polyfollicular, polycystic sort of ovary. Here, for example, is the constant nuisance of somebody who's doing these things, that we have a follicle that it seems to be within a follicle. It's not, it's neighbor, but in three-dimensional way. So in this case, you need to go to the lateral one, then to the internal one, and then to the small one. However, you need to be sure that you suck all the fluid from the first and second and the third one. So this knowledge of where is your tip, avoiding trauma, but mainly where is the blunt area that you can go close to the wall of the follicle, and then where is the opening to suck is the crucial point of a very good effectiveness on your technique. I don't need to talk about pseudomembranes. I think I exposed, just I give me 1-2 minutes more to show you some cases. For example, here we have an endometrioma and an ovary. The vascularity of ovaries with this is different. So you need to do color Doppler to avoid some big vessels. Here, for example, I put the strategy where we can go and suck all the fluid from all the follicles and without rupturing the endometrioma. And finally, we have this image of an empty ovary, full, all the follicles have been aspirated, and we have a 2.4 almost centimeter endometrioma in the corner. A rare case as well to show you that is important, that you can see, for example, on the top, the needle within the endometrioma. Very rare that we need to aspirate endometriomas. In this case, it was not any other option. For some reason, the endometrioma was on the top, and under there were a very nice sequence of very juicy, nice follicles. So it took me about 12 minutes with a largest caliber needle to aspirate the chocolate cyst fluid, and then I changed with a sharper, thinner one, and then I completed the OPU. So that was the initial part, and finally we are here. Final word about certification and training. In ESHRE guideline, participate as well about assessing competency. You can see the criteria. Basically, it's not only the number of the follicles. Yes, I got 12, I'm fantastic, or 14. You need to see as well from both sides what the expectation. So we need to talk now about number of oocytes collected, number of iron punctures, ratio of numbers of oocytes retrieved to the number of follicles aspirated, any complication immediately or long term, timing of your OPU. So, for example, I got 8 eggs, 8 oocytes from 9 from the right ovary, 6 eggs from 8 follicles from the left side, so total 14. I got 1 penetration in each ovary, so I have done 2 punctures, and I was thinking that I may have 10 based on 36 hours or 40 hours earlier before the trigger from the ultrasound. Now, when you do that and you are consistent on this, you will see different cases where you improve your effectiveness. Ideally, you should be 8 by 8, 9 to 9. This is not possible to happen. But if you optimize your technique, you will be as high to 90% of what you need to get. All the criteria about training, when you are supervised, when you are able to do that alone, how many opus you need to do to maintain your skills, and so on, are well written in ESHRE guidelines, so you can have the essence here. And for the trainees, if they listen to us, we need to get as well, not the numbers of the OPU, is the effectiveness of the OPU, meaning to get at least 80, even more if you can, of what you expect from your trainer. So if I got 14 eggs, my trainee should be, let's say, take 80% of 14, I think it's 11. So something like that. So it's important to see the ratio as well, rather than numbers of acts. I go very fast on artifacts. This is an interesting case. For example, you can see an artifact in the middle, shadowing everything, is a mess. I mean, it's a safe case here, but you don't always see. It's like if you see the ovary between curtains, and you can see the humongous artifact that happens because of this on the reflection. Still, the needle is there. Final words is that hyphosis, OPU, and embryo transfer are interventional ultrasound techniques. And more now, we need to consent the patient properly to tell them exactly what we know, to tell them exactly what we don't know, and who is doing what. So I'm working on in a paper actually about medico-legal issues in fertility, about ultrasound. So what is important is that the responsible doctor, maybe the operator, maybe not, this needs to be clear to the patient. And of course, the operator effectiveness can be assessed with audits. Some serious IVF centers, they do audits on their groups of doctors, but these are not necessarily public. So it's important that we maintain grossly a good effectiveness as a group. So I'm finished with showing a little bit my setup here in Athens. I give you my coordinates here, my email. You can follow in Facebook, in ResearchGate. You can download some chapters that the professor said that I participate writing in OPU and embryo transfer as well chapters. And in YouTube, I regularly put some examples of videos, and I hope that you can follow me and give your comments. Thank you very, very much for your attention, and I hope my presentation gave you an inspiration and some practical tips for a better effectiveness and better success of your work and pregnancy for your patients. Thank you very, very much.
Thank you, Costas, for a very interesting presentation. I have a few questions for you, but first, I want to ask you, are you doing all the ovum pickup with a Doppler ultrasound? So you monitor all the time the vessels around the follicles?
Always I do a quick scanning with Doppler, meaning that I have knowledge where are the vessels, not only inside, mainly outside, to be sure that I don't penetrate for somewhere I shouldn't, and as well for, it gives me a more confidence about the technique from where I will start, which sequence of follicles I will move on. Of course, you do that before. When you do the OPU, you cannot put the Doppler because you cannot see anything. So it's a quick assessment of each ovary. And when I finish my OPU, even if I'm happy and everything looks fine and it's okay, whether I got all or almost all the eggs, it's not that. I always record my opus, so I have a recording and recording at the end. So for the medical reasons, it's good to show that I check what I have been able to see and check, but as well for my learning. I was in an IVF unit where I was doing 20 opus per day. It's impossible in your mind to remember the second case, the fourth case, to know if you do well or not. Having small cine loops of 5, 10 seconds, if you want 30 seconds, it helps a lot to finalize your technique and your performance.
Thank you. By the way, do you rotate the needle at the time of aspiration, or you just put the needle and aspirate the follicle?
As I show you, I mean, first of all, when I go inside, I need to know finally how the needle looks like, where I am. So from the moment that I know where is my tip and where is my opening, then I orient. Yes, I move the needle, but mainly my probe. So then I start the aspiration, and then I see how the follicle behaves. So I try to avoid contact of the aspirational point of the needle with the wall, of course, because it will stuck, it will block, it will traumatize, it will be a mess. And then I try to be with my protected point of the needle in the higher, let's say high, closer to the probe place of the follicle. So all the fluid is concentrated in a place. So they can be in a spherical follicle, in middle part of the follicle, aspiration, the follicle collapse, then you need to retrieve progressively in order to have all around of the needle sort of the follicle. If you have follicles with a bizarre shape, banana, trapezoid, like or ovoid, then you need to think before for which area you will go in order to maintain a constant suction of flow. My opinion is this, that makes the difference, is that you have a constant suction of flow on the fluid. And that is depend the case. So yes, there is in left, right, and depending the probe, I orientate further the suction point of the needle close to the remain area of fluid. Sometimes you don't need to, but sometimes you need when you have this concentrated follicles around.
Thank you. There is a controversial issue whether to use, let's say in the poor responders patients, whether to use a double lumen needle and to flash the follicle after, each aspiration or before you take the needle out. What do you think about the benefits or the withdrawal or weakness of using a double needle and flashing all follicles?
For example, I had recently a patient, she was 45 and we had only 3. Now I'm confident that I can get them with 3. The funny thing is that we said, okay, I will prepare to do flashing, but as well, let's see if I can get it with the first one. We were able to do that with small bottles, and I got it. And I got it with the first sort of aspiration. That it depends of your own evaluation and confidence when you attack one by one the follicles. And the clarity. If you see and you do that, I strongly believe, I'm biased perhaps about this technique now, that you may optimize the technique. Now, if you don't see well, if you don't have good image, if you are not used to do all the settings, of course, the second chance with the flashing is useful. And you can discuss this with your colleagues, or it depends on the setup. If you are a solo, you can do what you consider the best. But if you are in a group, then you evaluate yourself with the other group in the similar cases, and then you find out what is the best interest for the IVF center of the group you work with. In my opinion, I believe that you can have the best results with a single lumen, one go, but only and only if you have perfect, clear image. If you don't, the flashing, it helps you, and as well, ethically and morally, that you have done your best.
Thank you, Costas.
Hope that I answer I answer, but
yes.
It is 2 ways. Yeah.
Thank you very much. It was really interesting presentation. Lots of clinical benefits for physicians, how to act and how to move at the time of ovum pickup. And I think it's very beneficial. So thank you again for your time and for your very interesting presentation.
Thank you very much. It was a great honor, and I wish great success in the continuation of the fellows speakers. Thank you very much again.
Thank you.